There are many challenges men and their loved ones face when considering their options for the treatment of prostate cancer. There is certainly no one-size-fits-all therapy, and quality of life measures including urinary control and maintaining sexual function are taken into consideration. Today, we will be discussing a technology, HIFU, or high-intensity focused ultrasound, developed to treat prostate cancer while aiming to minimize some of the potential side effects of prostate cancer treatment. So listen in. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. I'm excited to have joining us on the podcast today board-certified urologist and prostate cancer expert Dr. Jim Hugh from Weill Cornell Medical Center in New York. He completed his urology residency at UCLA and his urologic oncology fellowship at City of Hope National Medical Center. He was recruited to Weill Cornell Medicine in February of 2015 after establishing high-volume, internationally renowned programs at Brigham and Women's Hospital, Harvard Medical School, and UCLA Medical Center, where he served as director of the prostate cancer and robotic and minimally invasive surgery programs, respectively. He is internationally renowned as a surgical innovator and health services researcher. His research interests have been funded by the Department of Defense, National Cancer Institute, and the Livestrong Foundation. He has authored more than 300 peer-reviewed papers. He has performed thousands of robotic-assisted prostatectomies, among over 4,000 laparoscopic, robotic, and open procedures. He has really been instrumental in helping drive some of the advances that have helped the field of urology, including working with the FDA to look at the outcomes of HIFU, or high-intensity focused ultrasound, a type of targeted focal therapy for prostate cancer. Dr. Hugh, welcome to the Prostate Health Podcast.
Thanks so much, Garrett. Appreciate you having me on the show.
Well, so Dr. Hugh, the treatment of prostate cancer is constantly evolving as we continue to look at new technologies and advances in the management of the disease. Now, with these new advances, I am excited to be able to chat with you today about targeted focal therapy, and we'll be honing in specifically today on one of the technologies utilized, HIFU, for targeted therapy. But before we do, can you first explain to our listeners today what is focal therapy for prostate cancer?
Absolutely. So focal therapy contrasts with traditional paradigm of treating prostate cancer, which is whole gland treatment. And the reason why prostate cancer has traditionally been treated that way, that is the whole gland, is that in most men, it's estimated up to 3/4 of men, when they're diagnosed, prostate cancer is multifocal. In other words, it's just not located in one area within the prostate. And so traditionally, that's why the entire prostate was either removed surgically or irradiated. However, because of the advent of MRI targeting, that is getting an MRI before a biopsy and using a MRI fusion-guided biopsy system to try to better localize the prostate cancer, this has led to a natural extension of whether or not we can just treat that focus of cancer, hence the name focal therapy, or another term that's commonly used is partial gland ablation. So instead of whole gland ablation, it's partial gland ablation.
So what are some of the different technologies currently utilized for focal therapy?
Absolutely. So the most common options available, and I'll just start with something that's been used historically the longest, is actually cryotherapy. That's where needles are inserted into the prostate and an ice ball is created where those needles right at the tip. So that's been around and been done really in the United States probably for the longest period of time. Now, high-intensity focused ultrasound, which is the main topic of our conversation today, was approved by the Food and Drug Administration back in 2015, really for what's called prostate ablation. They didn't specifically assign a prostate cancer indication just because there was little data comparative data to delineate what the benefits of partial gland ablation would be for prostate cancer as it relates and compares to whole gland treatments. So those are the two most common options. There's also laser therapies, the use of lasers to, again, specifically target an area, but essentially you're using energy modalities like heat or cold to cause tissue destruction. There's also photodynamic therapy, and traditionally, of course, radioactive seeds were placed for whole gland treatment, and there's also the ability to place seeds just in the area where the prostate cancer is located or in a focal therapy manner.
Sure. So what is HIFU, and how does this technology work in treating prostate cancer?
Absolutely. So high-intensity focused ultrasound is just another, if you will, ultrasound technology. I think most men and healthcare providers are, of course, familiar with diagnostic ultrasounds. That is, for instance, when a woman is pregnant and has a prenatal visit, an ultrasound is used then to visualize the fetus in vitro or in the body. And so that same type of technology, that is using a transducer that emits these ultrasound waves, is also used in prostate cancer, although those waves are more powerful and cause heat and destruction of tissue. And typically, the waves have been employed using a transrectal transducer. So the ultrasound, the HIFU transducer is inserted into the rectum. The HIFU waves then cross the rectal wall and hit the prostate. Now, we alluded to this earlier. There is a transurethral high-intensity focused ultrasound methodology that just came to market really in the last, I believe, 6 to 8 months. And instead of a transrectal across the rectal wall delivery, that transducer is inserted into the urethra. So it kind of, if you will, treats the prostate from inside out.
So when looking at targeted focal therapy with HIFU for men with prostate cancer, who would you say are the best potential candidates for this option?
Absolutely. So ideally, I think you want to find someone with low volume prostate cancer. Again, going back to what we talked about earlier, that the majority of men have multifocality, that is prostate cancer in several areas. Typically, when you are going to treat men, for instance, that have a focus on the right side or the focus on the left side, I think you're going to set yourself up for a greater risk of failure in terms of finding cancer on a subsequent biopsy. So when we talk about, again, ideal candidates, when we look at prostate cancer, there's also what's called risk stratification, where we categorize men by looking at the grade of cancer, the PSA, and the clinical stage. And the combination of those three factors comprise what's called risk stratification. Men with low risk prostate cancer, because of the widespread acceptance of active surveillance, we do not think that those men need any treatment whatsoever. That is, the low-risk cancer doesn't have any biological potential to metastasize. So I don't think, and I think consensus is there, that we shouldn't treat low-risk prostate cancer. I think intermediate-risk prostate cancer, that is favorable intermediate risk, grade group 2 or Gleason 3 plus 4 equals 7, that, in my opinion, is the sweet spot because, as we know, this is a new paradigm. And if you offer this treatment to men with higher risk disease, that is, if they have unfavorable intermediate risk disease or they have high risk prostate cancer, those men are already at a greater risk when they're diagnosed that they already have metastatic disease. And so again, I think that what we'll see is that if there are any clinical trials done in this area or randomized controlled trials that compare the potential for high-intensity focused ultrasound and other modalities and compare them to traditional treatments, it should be with favorable intermediate risk prostate cancer. Now, that being said, of course, we know that for prostate cancer, a lot of men self-select themselves for certain treatments due to concerns about side effects. And I think we're going to talk about that a little bit more later.
And so what methods are you currently using in identifying the targeted area to treat the focal therapy? I know you mentioned one of them already.
Absolutely. So the MRI has really become, I think, increasingly standard of care to help diagnose prostate cancer. There's many professional guidelines that now advise men and their providers to get an MRI in the setting of an elevated PSA before they get a biopsy. Why is that? Well, in about a third of these men, the MRI may not find any abnormal signal within the prostate, and therefore those men may avoid a prostate biopsy. And in the men in whom there is an abnormal signal, that MRI can localize where that signal is within the prostate or where that lesion is within the prostate. And therefore, when you do the biopsy, which is typically fused or superimposed onto the ultrasound, which gives you a real-time picture, then you can more accurately sample that area. And so again, this has been a natural extension of the use of MRI in diagnosing prostate cancer. One of the challenges, I think, with the localization of the prostate cancer is that there's great work from UCLA and other places in which they've looked at the MRI and then compared it to the radical prostatectomy specimen in men who have had surgery. And then they're able to look at, well, what was the abnormal appearing lesion and what is the true extent of that lesion on the radical prostatectomy specimen. In some cases, they found that the true cancer extended beyond the border of the lesion on the MRI by up to 1.5 centimeters. And so that's led us as a field also to tend to overtreat or treat beyond that MRI abnormal area to get a better margin, if you will, to be cancer-free.
And are you seeing a templated biopsy still being utilized, or do you feel like we're pretty much switched over now to the MRI?
Most of the guidelines will continue to advocate for the templated biopsy. That is, typically for prostate cancer, you're spreading 12 biopsies throughout the prostate. Now, we've done research in which we've shown that typically, on average, about one of those systematic biopsies may overlap with that MRI abnormal area. But however, there's also a lot of research out there that shows that up to 15% of significant prostate cancers may also be MRI invisible. And so I think it is particularly important, particularly before focal therapy, that you have a systematic biopsy because, again, you're trying to map out the true extent of cancer and trying to get it right the first time, of course, when you get treated with high-intensity focused ultrasound, which is performed under general anesthesia, is ideal.
So for someone considering HIFU as an option for targeted therapy, what can a man expect with the procedure?
So the expectation is that you're going to have roughly, I'd say, under an hour and a half of general anesthesia. Now, an important consideration is that, again, in that epidemiologic group of men who have prostate cancer, there's typically overlap with benign prostatic hyperplasia or enlarged prostate in men over the age of 50, for instance. And so the overlap of those two conditions also leads to the consideration, is there a prostate that may be too big or too large for a high-intensity focused ultrasound? What I mentioned earlier is that the ultrasound waves, again, typically cross transrectally, so they're going from posterior to anterior. And so in the setting of someone who has a large prostate in an anterior lesion, for instance, the focal length of the high-intensity focused ultrasound may not allow you to reach that anterior tumor that adequately. The other consideration is that after a high-intensity focused ultrasound, there is, of course, thermal injury to the prostate, part of the prostate that's treated. That results in swelling. And men, particularly those with pre-existing BPH, they will have difficulty urinating afterwards. And so there are some cases in which we do a transurethral resection of the prostate, or we clear out that benign enlargement that comprises BPH. And so that also dictates what the total anesthesia time is if that is a combined procedure. But a man can expect that after the procedure, when he wakes up, he's going to have a catheter draining his bladder. The reason for the catheter, again, is that thermal injury causes swelling. There's a risk of being unable to urinate immediately after a high-intensity focal ultrasound procedure. That catheter is usually left in for about 1 week. When that catheter is removed, most men, again, the risk of HIFU is less than 1% chance of urinary incontinence. That risk is greater if those lesions are towards what we call the apex of the prostate, which is farther away from the bladder. But a man can expect there's going to be decreased ejaculate volume, or actually in many cases, no ejaculate. We found that despite the fact that one of the potential benefits of high-intensity focused ultrasound is that you're sparing the non-cancerous parts of the prostate, men oftentimes find that their ejaculate volume is significantly lower than it was pre-treatment. I think some of the side effects that you'll also find from high-intensity focused ultrasound are as a result of having that catheter in for a week. And what I mean by that is, of course, after having a catheter in for a couple of days, a biofilm forms on the catheter, and there's going to be bacterial colonization into the bladder. And so the urine is going to inherently have some bacteria, and that bacteria, along with the tissue destruction within the prostate that has occurred, does lead to a risk of urinary tract infections. And so sometimes it's not uncommon after a procedure to have some prostatitis. There's some men that get urinary tract infections that may cause what's called an orchitis, or a spread of the infection to actually the testicle. And then giving antibiotics for an extended period of time is going to help clear that up, as well as the fact that the catheter comes out again a week later. So those are the main expectations, going back to your question, Garrett, about what a man should look forward to after this procedure.
Well, you mentioned some of the risks involved with the procedure. Any other risks to consider? Or, if we've kind of covered all of those already, we could go on to what are some of the potential advantages of HIFU for focal therapy for prostate cancer?
Absolutely. So kind of dovetailing those two questions of risk and potential advantages, I think a lot of men, for instance, like the appeal of high-intensity focused ultrasound because of the concern of erectile dysfunction. And particularly, again, going back to our discussion about who are the ideal candidates, if you have someone just that has cancer on one side of the prostate, or what we call unilateral, then you're able to focus the energy, high-intensity focused ultrasound, on just that one side, and therefore you're not going near the neurovascular bundle or the nerve on the other side. Now, in some men, for instance, particularly those who are older, as we age, of course, there is a natural increase in the incidence of erectile dysfunction. And so they're not starting off with the best function. And despite the fact that you're performing ablation on just one side of the prostate, particularly if it's close to the capsule posterior laterally, there may be some damage to that nerve as well. I think the other benefit of high-intensity focused ultrasound is that it's an incremental approach, right? If there is a detection of prostate cancer on a subsequent biopsy, there's the ability to retreat or treat a different area again, and or you can also go to whole gland treatment options as well to try to salvage the attempted cure.
So in terms of following men after focal therapy with HIFU, in terms of monitoring for any prostate cancer recurrence or progression, what is your set protocol for following these men?
So I like to get an MRI and a prostate biopsy 6 months after the procedure. I think in others it may vary from 12 to 18 months, but I think that one of the temptations that men may fall into is that they may say, oh, I got my prostate cancer treated, we zapped that area, and never really go through the inconvenience, if you will, of having a prostate biopsy again. And that's unfortunately not the way to go because, of course, the untreated part of the prostate continues to make PSA, and therefore a reduction in the PSA is really not going to be that helpful to determine whether a man is cancer-free or not.
Sure.
I think the other thing to consider, of course, is as well, the untreated part of the prostate is at risk for developing cancer with more time, or potentially there may be undersampling with the initial diagnostic biopsy. And so that's the other significance of continuing to monitor with biopsies, is to pick up on those either de novo or cancers that are what we call out of field that may not have been picked up earlier. So the MRI followed by the biopsy is critical. Now, one of the challenges with MRI, of course, is that there's relatively less experience of interpreting multiparametric MRI signals in the post-treatment setting. So whereas we talked about earlier for elevated PSA, there's been a lot of experience kind of identifying 5 categories of risk. In this area, I think we need to do more research. Particularly for those men who are hoping to avoid biopsies, it'd be great to develop MRI experience and or techniques that can give us a lot of confidence that someone is cancer-free.
Now, you kind of alluded to this in one of our earlier questions, but again, are men still candidates for other therapy if needed after HIFU should they have a prostate cancer recurrence?
Absolutely. And I think that this is kind of where, and I'm sure we see this in medicine and you see this from a lot of your speakers, is that if someone, and it's just like anything in life, it's kind of like the old saying, if you have a hammer, everything's a nail. And what I'm alluding to is that I think as a prostate cancer expert, someone who can truly offer all options to patients is going to be able to help the patients in a shared decision-making process choose the best treatment for them. And what I mean by that is I started my career doing robotic prostatectomies, and if I just did that alone, I think there'd be a subconscious bias of trying to convince men to have surgery all of the time. Now, again, if you are comfortable with MRI targeted biopsies, then you're naturally going to be comfortable following men with active surveillance. And that same approach then sets you up as a provider to have a comfort level with choosing patients, the ideal candidates for focal therapy, as well as doing the subsequent biopsy. And so getting back to your question, those who recur, yes, I think if you, for instance, see someone who does focal therapy, they're probably more likely to try to pigeonhole the patients again into doing focal therapy again. But I think that that's where having a broad spectrum of the view of prostate cancer and the treatment options available is going to help in counseling that particular patient what the best treatment option is going to be.
Sure. So what does the future hold for HIFU and the management of prostate cancer? And do you see this option really making its way into current guidelines and even more widely accepted as standard of care for appropriate candidates?
Absolutely. So let me take the second part of the question first, which is, the partial gland ablation HIFU making it into the guidelines. And so professional societies like the American Urological Association, often look at the grade of evidence before they publish guidelines or opinions about what to do. And so currently, when you look at high-intensity focused ultrasound, there's been some single-center series. There's been some centers that have started pooling data, but most of the biopsy information is limited to that first anywhere between 6 to 18-month biopsy. So long-term outcomes with biopsies are limited. Now, the other thing that we've observed is that in many of these series, up to 30%, a third of men are not getting those subsequent biopsies. And there's published studies from Europe, for instance, that look at long-term PSA follow-up. They look at the likelihood of subsequently developing metastatic disease. But again, someone may have prostate cancer for years before a metastasis has clinical significance in terms of causing pain or fracture. So these are some of the blind spots in terms of the lack of evidence that is going to lead to the HIFU or partial gland ablations not being mentioned as an option in guidelines for some time. In comparison, for instance, we have radical prostatectomy, which in its current form has been performed for more than 50 years. That is the retropubic approach. Longer if you consider the perineal approach to radical prostatectomy. Of course, radiation was more popular in the 60s and 70s because surgery at that time was very morbid. So in other words, you have more established treatments that have much longer track records as compared to these relatively new partial gland ablation approaches. And so that difference in experience, the lack of comparative evidence, is going to keep high-intensity focused ultrasound and focal therapies out of the guidelines for some time. So going back to now the first part of your question, which was, what do I see as new modalities that may be coming out? Again, I'm excited about the transurethral high-intensity focused ultrasound delivery. Part of that, of course, is, as we talked about earlier, you don't have the limitation of the focal length, the need to travel across the rectal wall. It's a shorter distance originating from within the prostate. I think some of the data looks very good in the device manufacturer's multi-center trial. And I think that ultimately there needs to be better, again, our advancement of MRI and some of the newer molecular imaging modalities. For instance, there's prostate-specific membrane antigen that has had a lot of excitement because of its FDA approval for use at a couple of institutions on the West Coast. I think that as we kind of merge the ability to look at multispectrometric MRI with some of these molecular imaging types, again, this is years down the road, that may lead to the better localization of the cancer, which again has been the Achilles heel, the need for us to treat a couple of centimeter or so beyond the lesion because we're not sure if cancer extends beyond that border on the MRI. So those are really the gaps that I think we need to cover and will be covered for this to be a more widespread treatment option. Well, certainly I appreciate your kind of wisdom and kind of perspective there. So Dr. Hugh, any final thoughts for our listeners today? I think that, it's an exciting time. I think that choice is a good thing. I think when we talk about, for instance, consumers of healthcare or consumers overall, for instance, I think we can see how the consumer has increased power when something like Amazon comes in and gives us more choices, right? And similarly, with prostate cancer, the more choices that we have, the better. I should mention, just as a caveat, Garrett, that some of the studies that have looked at short-term outcomes in terms of looking at a subsequent biopsy after partial gland ablation, the likelihood of finding clinically significant cancer has ranged anywhere from 20 to 40%. So again, some people may say that is high, but on the other hand, for a man who feels that the risk of incontinence or the risk of erectile dysfunction is just, debilitating, if they get that, they may want to give partial gland ablation a first shot. Of course, making sure that they get a biopsy 6 months later and determining whether that the treatment was effective and subsequent biopsies after that. So I think that that's just something that to keep in mind as we're evaluating and talking to our listeners today about this new treatment modality. Well, it has really been a joy getting to chat with you today on the Prostate Health Podcast, and you've really provided significant value today for our listeners. Thank you again, and for taking time out of your busy schedule to visit with us. It's my pleasure, Garrett. I'm glad you're doing this for patients as well as providers to get the word out. Well, thank you again. You bet. My pleasure. Thank you again for listening to the Prostate Health Podcast. We would love to have you join our podcast Facebook group at
www.facebook.com/groups/prostate health podcast, or just use the Facebook group search function and search for the Prostate Health Podcast and ask to join. We'll see you at the next episode.